I'm Seth Oliveria. I'm a neurosurgeon at the Providence Brain Spine Institute. I'm the director of functional neurosurgery, and I also work for the Oregon Clinic Neurosurgery. And today we're going to be talking about deep brain stimulation and what to expect with surgery. This talk is similar to what we discussed when a patient comes in to see me in clinic, and oftentimes, I would hope that you'd be able to share some of this information before we start talking about an individual specific plan for surgery. So this is intended for people who are considering surgery and want to gain more information before committing to that process. I work primarily at Providence St. Vincent's in Portland, and I also work at Portland Providence downtown. Our DBS surgeries are performed primarily at Providence St. Vincent's. That's where we've chosen to consolidate all of our specific operative equipment that we use for this procedure. And so to get started, deep brain stimulation is a FDA-approved surgical procedure for several different neurologic disorders. The most common use is for Parkinson's disease, followed by essential tremor, and then dystonia. And then a relatively new use that's FDA-approved is for epilepsy. There are also several other investigational indications and targets that you may or may not have heard of on the news, but those are all typically reserved for clinical trials and are not FDA approved. So deep brain stimulation compared to other procedures for movement disorders is characterized by being not ablative, meaning that it is intended to alter the activity of malfunctioning brain circuitry and not to specifically damage it, as opposed to other kind of procedures where various areas of the brain can either be burned or resected in certain ways to affect the functioning of brain circuitry. Typically, DBS is not considered curative. Many of the movement disorders that we treat with deep brain stimulation have a progressive nature, and they do tend to continue to progress despite deep brain stimulation, although it can be very beneficial for many of the symptoms. And DBS at this time is only indicated for medically refractory conditions, and that means conditions that are not being controlled with medication alone. Generally, DBS is not a first-line treatment before you try medications. So as part of the evaluation to determine if you're a candidate for DBS, several tests will be performed. First and foremost, either in a neurosurgery office or commonly in the neurology office, you'll have a detailed medical history and examination, and this is oftentimes followed by a brain MRI. And then based on the individual's needs, several other tests may be performed, including neuropsychologic tests, physical, occupational, speech therapy, or other referrals such as psychiatry. And these are oftentimes quite tailored to the individual to help us do the best job of predicting your response to DBS and any potential problems you may or may not have related to the surgery. And not everyone gets all these tests done, but oftentimes they can be very helpful for our counseling for you before surgery. And then once all this evaluation is complete, then the neurologist and neurosurgeon work together to discuss your case in detail, determine if you're a good candidate for deep brain stimulation, and if so, for certain conditions, there are more than one target in the brain, and to decide what is the best target for stimulation. The deep brain stimulation system consists of three components. First, there is the lead, which is the business end of the device, and I'll try to point here that you can see that the thin wires that go into the deep part of the brain, which is shown here on the cartoon, is the end where the actual stimulation occurs. Then the second part is a thicker cable called the extension cable, and this connects the lead to the final part, which is the neurostimulator, also referred to as the battery, which is essentially a small computer that's implanted under the skin in the region of the collarbone. There are two stages to the procedure. Part one is typically the part that involves implanting the electrodes into the brain, and then part two is essentially wiring up those leads to the neurostimulator, and that involves passing electrodes under the skin, behind the ear, down to the chest. And these procedures can be performed either in 2 stages if necessary, or sometimes all as a single stage, depending on the specific needs of the patient. Commonly at our center, we're frequently performing those all as a single surgery, but that decision is made based on the individual needs of the person undergoing surgery. So just to give you an idea of what the surgery entails, we start by doing planning of the trajectory of the electrodes through the brain on a high-resolution MRI that's shown here, and these colored lines indicate the location of the intended target in the brain and how to get there safely through the brain without causing any neurologic problems. And then the day of surgery, what we do is we make a small incision in the scalp and we drill a hole through that skull to expose the underlying brain. That little hole is about the size of a dime. And then there are several different strategies to ensure that we place the DBS electrodes very accurately at the target within the brain. And there are several different ways to do that. Some of those are shown here. So this is called a stereotactic head frame, and it's this kind of medieval looking device that allows us to very precisely point along that trajectory to the target in the brain. And this is what it looks like in the operating room, where this is sort of a sterile drape over the patient's head. And then this is that frame that you see here on the mannequin on the right. There are other devices, they're so-called frameless devices that mount directly at the site of the incision as opposed to a separate head frame. And there are pluses and minuses to those different procedures depending on kind of the goals of the surgery. And then some centers use what are called microelectrodes or microelectrode recording, where through that same trajectory, an electrode is passed down into the brain, and each of the different areas in the brain have a different signature of activity that can be seen with electrode recordings, and you can use that to determine if you're in the right place in the brain with neuromonitoring. And then kind of one of the things that DBS is famous for is that we can do awake testing, where the patient is actually asked to do certain tasks in the operating room awake while we stimulate the electrode that's implanted in the brain. And that's sort of the gold standard. There's no better way to test that the electrode is where we intend it to be than to turn it on and make sure that the patient's symptoms are getting better in front of us. And that's something that many people have seen, kind of videos of patients in the operating room undergoing that. And it's kind of a remarkable part of the procedure. And then kind of a newer development is the use of image guidance. As imaging, both MRIs and CAT scans have gotten better and easier to use in the operating room, we've started using more and more imaging. And so there is the possibility of doing deep brain stimulation surgery completely asleep, where you give up the testing I showed on the last slide and you replace that with high resolution imaging. And so the next step, I want to kind of tell you my own specific way of approaching DBS surgery, and it's a little bit of a combination of several things I've talked about. And every center that does deep brain stimulation has a little bit of a different approach. The way that I do it, I think we've gotten very reliable and accurate results, and so I'll just explain that here briefly. So I just start the surgery with the patient under general anesthesia. And while the patient is asleep, we do several steps, including numbing up the entire scalp and placing one of those frames on the head. And then we do the incisions and do all the drilling, and we place the leads within the brain. And then while the patient is still asleep, we do a CAT scan to ensure that we are happy with the location and that the electrodes are implanted very accurately within the brain. And then at that step, here's an example of that, where the colored lines are shown on this image that show our intended targets within the brain. And then the white shiny images that you may or may not be able to see, underlying those colored lines show the position of the electrode on the CAT scan. And then that's merged with the patient's preoperative MRI and basically confirms that those electrodes are exactly where we want in the brain. On this patient, if you see on the right, it says 0.3 millimeters, and that's where the electrode is relative to where we intend it to be. So that's very, very accurate and precise. so after that step, once we are confident that with the location of the electrodes within the brain, at that point, I asked the anesthesiologist to wake the patient up from anesthesia. And it looks similar to this picture on the right side here. And we do a little bit of brief testing by stimulating those electrodes to ensure two things, both that we see benefit in terms of the patient's symptoms, but also that we don't see any negative side effects that would prevent the electrode from being used the way that we would like it to. And then after that step, we just close the skin and we're done with the surgery. And this image here on the right side here shows kind of an example of why we do that. So this cartoon here shows the a representation of the thalamus, which is where we put electrodes for essential tremor. And these little pictures show a representation of the body for different processes that the brain controls. So this picture, this image here is of all of the motor areas in the brain, the hand and the leg and the face. The circle here indicates where we intend the electrode to go within the brain, and this is in the kind of motor control areas of the thalamus. And directly behind this is the sensory areas, for sensation in the body. And if we put the electrode within the circle, the results in terms of tremor control are extremely reliable. But if we go just the diameter of the circle is about 2 to 3 millimeters. And if we go outside of that circle, then we're likely to stimulate the motor areas in the brain, or behind that, the sensory areas. And if you stimulate the motor areas, you get contraction of the muscles when the device is turned on. If we stimulate the sensory areas, oftentimes people report that as tingling or pins and needles feeling that can be bothersome. And those are things that can really limit the ability to use the device down the road. And so by testing that in the operating room on top of the imaging tests that we do with the CAT scan, we feel very confident before we leave that the electrode is exactly where we intend it to be. This is an example of a patient who is undergoing the surgery. You can see their video of their hand movement during the procedure. And you'll see that on this video, we're stimulating the right side of the brain and testing the left hand. So we'll be testing this hand, and you'll see that we're asking her to do spirals with her hand like this. And you'll see on this video that she typically has a very symmetric tremor, but in this image, it's much improved with the stimulator on the left side compared to the right. So that's a very good quick indication that the electrode is in the right place and providing symptomatic benefit. And this is another example where we do the awake testing. This is a patient who also has a central tremor. You can see the white spot is where the electrode is in the brain, and it's almost exactly overlying the intended target with this colored line. And when we awoke the patient, she saw a good improvement in her tremors, but she complained of very bothersome tingling in her hand and in her face when we turned the electrode on, despite having good tremor control. And so what we did, and so what that indicated is the electrode is a little bit too far back into the sensory areas, even though it's right where we want it to be. And so what I did is I moved that electrode back along its trajectory 0.5 millimeter. And when I did that, she said that the tingling was much less bothersome. And I moved it another 0.5 millimeter, so 1 millimeter total, a very tiny amount of change from our intended target. And she said that all that tingling went away, and she still had good control of her tremor. And that process took an extra 2 to 3 minutes in the operating room and saved her a lot of problems down the road with her stimulator. And this is that same patient that I just discussed, her writing sample before and after surgery, and she had a tremendous benefit, and we were glad to be able to avoid some of those side effects with that testing. And this is one more final example where we do some of that awake testing. This is again that picture of the thalamus for essential tremor, and that kind of as the same as this image of an MRI on the right. This black spot is the deep brain stimulation electrode in that area of the brain. And if you can tell so on one side of the brain, it's right where it needs to be. On the other side of the brain, it's outside of that structure, just slightly. And I had a patient referred to me who'd had deep brain stimulation performed elsewhere. And when she came to see me, she had good benefit, as we would expect from this electrode that's placed on this side, but not the one on the other side of the brain. When this one was turned on, it caused motor contractions in her hand and in her face that made it so she couldn't use that side of of her stimulator. And this is an example. This is her tremor before surgery, which is pretty dramatic. This is with her stimulator on. And you can see that she still has quite an impressive tremor. And then, so what we did was we moved that electrode that was misplaced 2 to 3 millimeters towards that structure. And you can see after surgery that she had, a good control of both sides of her body with her stimulator. And it just goes to show that that 1 to 2 millimeter change that we can do in the operating room makes a big difference in terms of preventing side effects down the road. And so while it is sometimes worrisome to patients, it's very kind of comfortable, and most patients actually don't remember the testing afterwards because you're still a little bit groggy from anesthesia. But we've had really good results with just kind of some very brief testing in the operating room to avoid potential problems and to make subtle adjustments like I've shown in these videos. And so then, so that's all, what's considered part 1 of the surgery. Part 2 is the connection to the stimulator that goes in the chest. And here's just some x-rays showing so this is the electrode going into the brain and then going outside of the skull. And here's the little connection to the extension cable. And then that runs down the neck and then to the chest as shown here. The patient allowed me to show his incisions, and you can see this is what they oftentimes look like once they've healed up, both in the head and then in the chest. And generally they are fairly once we're well healed, they typically cosmetically are pretty acceptable. This patient I chose specifically because of his hairline, so you could see the incisions. Most patients who have they're behind the hairline and they're completely invisible after they heal, and the hair and they're within the hair. And then kind of after surgery, a few weeks after you're done with the operations, most patients will go back to their neurologist to have the DBS system turned on and to do the initial adjustment of the DBS settings. We don't turn it on right away after surgery because there's a little bit of swelling around the tips of the electrodes that affects the settings. And if we were to turn it on right away, that your settings would change over the next 2 to 3 weeks as that swelling goes away. So we typically let you recover from surgery and then allow you to go back into the office for the initial activation. And typically it takes a few sessions with the neurologist before the ideal optimized settings are determined. Oftentimes people get benefit as soon as it's turned on, but it can take a few adjustments before we get to the final settings for you. And typically we expect that you can return to most, if not all, of your usual activities after surgery. There are very few limitations related to the device. The primary one is that you can't be around big magnets or high voltage machinery, and in most people's lives the most common place that they would run into that would be an MRI scanner. If you needed an MRI of your brain or any other part of the body, it's not that you can't get that. The MRI devices are typically MRI compatible, but it needs to be turned into a specific setting before you're allowed to do that. But generally, other than that, the limitations are very minimal from having the device implanted. A common question is whether you can go through the metal detectors at the airport, and the answer to that is yes, you can. This is brain surgery, and I like to tell people, this is one of the few elective brain surgeries, and the risks of that elective brain surgery have to be outweighed by the potential benefit. And in these surgeries, the benefit to a patient is very high. You can have real dramatic improvement in your quality of life, but we have to make sure that it's still worth the risk. There's 3 types of risks with DBS surgery. The most common one that we worry about, most often is, related to the wounds or the device itself. And in particular, early on after surgery, we worry about wound infection. You'll end up having 4 incisions, 2 on the top of the head, 1 for the little connection behind the ear, and then 1 on the chest. And all 4 of those incisions, there's hardware, the wires and the battery right under the skin. And if you get a superficial infection, it can very quickly spread down to the battery. And so we're very cautious and protective of those incisions, and try to keep a very close eye on it. And if there's any concerns, we're very kind of quick to take a look at it and see if you need antibiotics, etc. The second category of risks are related to the electrical stimulation itself, and those can be perceived several different ways in terms of tingling and numbness, as I described, or contraction of the muscles. Sometimes people can have speech problems or mood problems, and the vast majority of all those things are transient and reversible and are related to the electrical activity that we're using with a stimulator. And typically, if people have side effects like that, we assess for those in the clinic and try to adjust it before you leave the before you leave the office. And sometimes you get home and you have some issues, and we can adjust the stimulator further as necessary by having you either come back or talking about it over the phone oftentimes. And then the third category is serious complications such as brain hemorrhage, stroke, seizure, brain infections. Thankfully, those serious complications are exceedingly rare, less than 1% of the time. And really the way we avoid those serious complications is by all the things we talked about at the beginning, by putting the electrodes in very safely and very accurately, and avoiding kind of the blood vessels in the brain. If not that those things don't happen, but our goal is to make those as rare as possible. So that's the first part of the talk, which is about deep brain stimulation in general. And then I do have a few extra slides that are specific to Parkinson's disease, because that is, compared to the other things that we talked about that we use DBS for, which include essential tremor or dystonia, or more recently for epilepsy, deep brain stimulation for Parkinson's disease is a little bit more complicated, in part because Parkinson's disease is a very complex disorder. And so a few slides specific to that. If you have one of those other conditions, you don't need to continue to listen if you don't want to. But for patients with Parkinson's disease, I wanted to go into a few issues in detail. As many people who are watching this probably know, Parkinson's disease is a complicated disease with several different symptoms. The classic symptoms are a combination of tremor, rigidity, bradykinesia, which is slow movement, and postural instability, which is problems with walking and with balance. And the cause of Parkinson's disease isn't entirely clear, but involves a combination of genetic predisposition and environmental factors as far as we know. And the symptoms tend to arise as the neurons in your brain that produce dopamine start to degenerate. And that loss of dopamine is what leads to most of the symptoms of Parkinson's disease. And so medical treatment for Parkinson's disease involves replacing dopamine in different ways. And initially, that's typically very effective for a lot of patients, but there are limitations to that. As many people know who have Parkinson's disease, you have to increase your dose over time. And as you increase the doses of those medications, you start to have side effects. And those can involve dyskinesia, hallucinations, early wearing off of the medications, and unpredictability of the medications. And so what happens, and this chart explains this, is that as you take your medications, the dose of medicine in your blood, or sorry, the dose of dopamine in your blood and in your brain kind of goes up and down throughout the day. And this dotted line describes the window where you get benefit from your medicine for your symptoms. And initially, when you start taking medicine, you get good benefit because you're within this window. But as you lose dopamine producing cells in your brain, that window gets more and more narrow over time. And then you start to be where you're either having not enough medicine in your system, and that's oftentimes referred to as off symptoms, or you can have too much medicine in your system, and that's when you get side effects like dyskinesia, and you spend less and less time in the sweet spot, what we refer to as on time. And many people I see for DBS oftentimes are constantly overshooting and undershooting that sweet spot, that therapeutic window. And so what DBS does in a very simple manner is it opens up that therapeutic window, that sweet spot where your medicine works, and it narrows those sort of swings up and down, and you spend more time in that window of good time, or what we call on time. This is an example of that, that dotted line essentially gets wider, and the ups and downs get less sort of severe, and you spend more time in the on state instead of the off state or the overdosed dyskinetic state. And so this is a now relatively old study that was in the New England Journal of Medicine back in 2006 that tested people with DBS, deep brain stimulation versus optimization of medical management for 6 months. And essentially across all the different tests, including mobility, activities of daily living, emotional well-being, stigma, discomfort, social support, cognition, communication, all those tests, DBS, which is the dark bars, did dramatically better than further optimization of medical management for people who qualified for this study. And so it just showed that, really there's a, profound improvement across, many different measures for people who are good candidates for DBS versus continuing with medication alone. And, one thing we talk about a lot with each individual patient is whether they're a good candidate for DBS. And, these are just kind of a list of things that, that aren't hard and fast rules by any means, but, tend to kind of, make you a better candidate for DBS. And the first one is actually kind of more of an FDA regulation that typically we like to see that patients have had Parkinson's disease for at least 3 years. And that's not, like, as I said, a hard and fast rule, but, something that's typically a rule of thumb. A real common indication for DBS is people who get good benefit from their medication, but it's transient and they have fluctuations between on and off states that just kind of, are constantly, fluctuating throughout the day, and that can be associated with dyskinesia when they overshoot and have too much medication in their system. And then kind of simply related to that's the next line here, that there's a good response to Parkinson's medications, but the duration is insufficient. And oftentimes another kind of good indications, you've tried lots of medications, you get some benefit, but it's inadequate to fully treat your symptoms. And then as sort of another kind of issue with people with Parkinson's disease, that some people have a medication refractory tremor, meaning that it doesn't respond to medicine even from the very beginning. And that's something that can be treated with DBS regardless of your responses to medication. And then this, is related a little bit to what we said in the first part of the talk, but, what to expect after DBS surgery for people with Parkinson's. Most people with Parkinson's continue to take medication after DBS. Some people are able to decrease dosages of the medication. In rare cases, people are able to stop taking medication altogether. Oftentimes one of the biggest benefits is reduction of the side effects related to their medications, and in particular dyskinesia, which is that kind of extra dance-like movement that people get when they're on high doses of medications. And then one thing, as we said at the very beginning of the talk, is that Parkinson's disease is a progressive disorder, and the symptoms do continue to worsen, unfortunately. But despite that, the benefit of DBS persists, even though symptoms may continue to get worse. And to a certain extent, the device can be increased in stimulation to follow that worsening of symptoms, at least to a certain point. And even when, symptoms are get bad enough to where they exceed the limitations of the DBS system, there's still a significant benefit. And one of the classic things is people say that their tremor is coming back and they're worried the device isn't working. And if we turn it off, we see that their tremor is way worse than it was before they ever had surgery, but they get a good benefit, but it's essentially emerging past the DBS device. And that is different in terms of that timing for different people. But even though, the DBS device can't prevent all symptoms, you still get a lasting benefit for the lifetime of the device. So I'm going to stop there. And as I said, this is oftentimes, considered a precursor for people who are considering surgery. And what we, do is we actually have people come into the clinic and, discuss all these things in detail, and then tailor the surgery to the individual patient. So I'll stop there, and thank you for your time.